Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector. The virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty at your workplace. So I would like to urge you to sit back and spare me part of your precious time as I share a few tips with you. So welcome to part 19 of our series. In question 1, according to the AGS 2015 updated BS criteria for potentially inappropriate medication use in older adults, which of the following statements is true regarding nitrofurantoin? Is it isn't recommended in older adults, or is it isn't recommended in older adults with a creatinine clearance of less than 60, or it isn't recommended in older adults with a creatinine clearance of below 30, or its use is now recommended for all older adults without regard to their renal function? I'll give you 10 seconds to choose the correct answer. In my opinion, the correct answer is C. Now, the recommendation to avoid it in patients with a creatinine clearance below 60 was revised in the 2015 update. There is evidence it can be used in patients with a creatinine clearance of 30 or greater for short-term therapy, not for prolonged prophylaxis, but for short-term therapy. Let's move to the next question. Which of the following best describes the mechanism of action for Malathion? Is it a carbamate? Is it an organophosphate? Is it a cyanogenic glycoside? Or is it a glutamate gated chloride channel opener? I'll give you 10 seconds to choose the correct answer. I would settle for B. In my opinion, it is an organophosphate. It is technically an organophosphate used in the treatment of head lice, which we call pediculus humanus capitis, and it can also be used for pubic lice, pediculus pubis, and it belongs to the same class as parathion. Now, following systemic exposure to the two that I've just mentioned, what we call the cholinergic toxidrome results. Therefore, their use is restricted and should only be topical. You should only apply them topically. Never use them orally or on broken skin surfaces. Now, patients and caregivers should take extreme caution and avoid any internal ingestion or excessive topical exposure when using those two. Now, carbamates act in a similar way to organophosphates, but this particular product is not a carbamate. Then cyanogenic glycosides, just for your information, are compounds which contain cyanide, and they are not used to kill lice. They are not used as pediculicides. Now, just for your information, ivermectin opens the glutamate gated chloride channels in lice. So if the question was about ivermectin, then D would have been the correct choice, but it doesn't apply to Malathion. Let's move to the next slide. A 59-year-old female with a known history of alcohol abuse for the past 22 years is now experiencing signs and symptoms of mild cirrhosis. The liver is giving way. She desires to quit drinking but says she needs help because she can't overcome those serious cravings when she tries to abstain. Now, which of the following have been studied and shown to reduce some of the cravings of alcohol and lead to improvement in abstinence? You can choose one or more from the list. Is it baclofen? Is it disulfiram? Is it fluoxetine or gabapentin? I'll give you 10 seconds to choose from that list. In my opinion, both baclofen and gabapentin would do. Baclofen and gabapentin have been studied in randomized controlled trials, and they have shown the ability to help with cravings that may also improve the rates of abstinence. Now, disulfiram, which is also called antabuse, is an inhibitor of aldehyde dehydrogenase, which can result in the accumulation of acetaldehyde when alcohol is ingested by a patient who takes the same, and this results in serious nausea, vomiting, and I would just like to emphasize that it does not treat cravings in alcohol withdrawal or attempts of abstinence. And then metronidazole, when administered with alcohol, can lead to disulfiram like reactions. Just as a by the way, let's move to the next slide. Which of the following abnormal lab tests may indicate alcohol abuse in a patient? Would it be elevated A1C, or elevated liver function tests, or high folate levels, or a slightly elevated MCV? I'll give you 10 seconds to choose the correct answer. So I would settle for answers B and D. It would lead to elevated liver function tests and slightly elevate MCV. Now, alcoholics can present with the following when labs are done. You can have elevated liver function tests, elevated GGT. They can even show signs of microcytic anemia, which is usually seen with elevated MCV. Electrolyte imbalances can occur, and they are usually low and not high folate levels, which leads to an elevated MCV and macrocytic anemia. Now, alcohol consumption affects the body's ability to absorb folate. That is why it would be low and not high, and that increases folate in urine. Less is absorbed, more is passed out in urine. And then excessive alcohol consumption can cause chronic gastritis, leading to anemia and a slight high mean corpuscular volume, what we call the MCV. Now, the effect of alcohol on A1C varies from one individual to another, so I would not categorically say it elevates or decreases A1C. Let's move to the next question. A 45-year-old female undergoing treatment for alcohol dependence is given Naltrexone, what we call Vivitrol. My question to you is, which of the following statements below is correct about the use of Vivitrol? Is it can be injected sub-Q on a weekly basis, or is it shouldn't be used in patients on narcotic analgesics for chronic pain management, or is it can be taken orally daily, or is it D, it is approved for irritable bowel syndrome with predominance of constipation? I'll give you 10 seconds to choose the correct answer. So answers B and C are correct in my opinion. Now, naltrexone is an opioid agonist which is indicated for alcohol and opioid dependence and shouldn't be used in patients on opioid analgesic for chronic pain management, because there's a risk there, a risk of reversal of the pain control. You would lose the gains that you've made by using the narcotic. It can be administered orally, daily, or as a single IM injection every 4 weeks at a dose of 380 milligrams. Now, there are no dosing recommendations for the sub-Q route on a weekly basis, so I would not categorically say that would be feasible. It can also be used off-label for cholestatic pruritus. So let's move to the next question, which reads, which of the following is first-line treatment for patients who have overdosed amphetamines and are experiencing agitation and convulsions? Would you put them on amiodarone, diazepam, nitroglycerin, or esmolol? I'll give you 10 seconds to choose the correct answer. So I'll comfortably use diazepam, which is a long-acting benzodiazepine which is commonly used in patients with amphetamine overdose who are experiencing severe agitation and convulsions. Now, monitoring vital signs of a patient with an amphetamine overdose is very key, even though you may administer the diazepam, because any serious complications need to be treated. Now, amiodarone, in my opinion, may be used to manage any arrhythmias that may occur due to this kind of overdose, to address the arrhythmias, not the convulsions and not the agitation. Then esmolol, which is also called Brevibloc, may be used to treat tachycardia that arises from this overdose, not the convulsions and not the agitation. And then nitroglycerin, in my opinion, may be used to manage any hypertension that may result from amphetamine overdose, not agitation and not seizures. So that makes answer B the most accurate and optimal choice. Let's move to the next question, which asks, in which of the following drug addictions can methadone be used? Is it in cocaine, heroin, LSD, or PCP? I'll give you 10 seconds to choose the correct answer. It can be used in heroin addiction. Now, there is no FDA approved medication to treat cocaine addiction in literature, so answer A is wrong. Medication used to treat heroin addiction include buprenorphine co-administered with naloxone, methadone, and naltrexone. So that makes B an optimal choice. And methadone is known to prolong QT interval, just for your information, and it's associated with clinically relevant drug-drug interactions with via the CYP3A4 route, and it has a long duration of action with a half-life of around 9 to 87 hours. It is a weak antagonist of the activity of NMDA receptors. So let's move to the next question. Which of the following information is important when dispensing a prescription for Concerta to an adolescent who is school going? who has been accompanied to your clinic by the parent. Would you encourage the parent to talk with their kid about not sharing their pills? Would it be to leave the prescription on the kitchen table for anybody to access and fill at the nearest pharmacy? Would it be to store the drugs in the fridge to prolong the shelf life? Or would it be to double the dose without consultation when they feel they need more? So I'll give you 10 seconds to choose the correct answer. I would settle for A. Now, prescription stimulants such as methylphenidate, Concerta, to be specific, are being more frequently abused by the teens and the young adults as we speak. It is therefore important to tell the patients and their parents about potential misuse and discourage them from sharing, because those others they share with would be drawn into the addiction and the practice of abusing such drugs. And methylphenidate, which is Concerta, has a similar mechanism of action to cocaine. It primarily inhibits the reuptake of norepinephrine at the presynaptic terminal nerve. So we need to be cautious, discourage them from sharing unnecessarily. It is a prescription only drug, and there is no need to refrigerate it, and we shouldn't double the dose without the doctor's consent. The next question reads, which drugs of abuse can have frightening flashbacks as long-term adverse drug effects? Is it amphetamine, LSD, cocaine, or PCP? I'll give you 10 seconds to choose the correct answer. So LSD does this. It can have hallucinogen persisting perception disorder, what we call HPPD, where an individual experiences frightening flashbacks. The others do not cause that adverse drug effect. So let's move to the next question. A patient is having a toxicology drug screen. Which of the following drugs listed below could be detected up to 30 days from the last dose? Is it amphetamine, marijuana, cocaine, or oxycodone? I'll give you 10 seconds to choose the correct answer. Marijuana it is. The detection time for chronic heavy, that is daily use of marijuana, is up to 30 days. Now when it's moderately used, it's up to that is up to 4 times a week, it is 5 days, and if it is daily use, it's up to 10 days. Now for the case of amphetamine and oxycodone, it's up to 3 days as quoted in literature, while for cocaine it is between 2 hours and 1 day. So the correct answer is B, marijuana. Let's move to the next question. A patient reports to the clinic desiring to quit smoking. You make a choice to initiate Zyban, Bupropion in him. Now, which of the following most accurately describes its mechanism of action? Is it a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptor, or is it a weak inhibitor of norepinephrine and dopamine reuptake, or does it block the reuptake of both norepi and serotonin, or is it an alpha-2 receptor agonist? I'll give you 10 seconds to choose the correct answer. So B it is. It is a weak inhibitor of norepinephrine and dopamine reuptake. Now Zyban is marketed both as an antidepressant and a smoking cessation aid. It is a weak inhibitor of norepinephrine and dopamine reuptake, and it leads to an increase in their levels at the nerve level, and it's presumed that the increase in dopamine is partially responsible for its efficacy in smoking cessation. That is, the dopamine influences the decrease in cravings. Now, the first mechanism of action applies to varenicline, which is a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptors. And those receptors on activation release dopamine, which decreases nicotine cravings during abstinence or smoking cessation attempts. Now, nortriptyline, which is a tricyclic antidepressant, blocks the reuptake of norepinephrine and serotonin in the CNS. It would apply to C. That mechanism does not apply to Zyban. Now, clonidine is a centrally acting alpha-2 receptor agonist, which when activated has inhibitory effects leading to a decrease in sympathetic outflow. So choice D would apply to clonidine. Now, both clonidine and nortriptyline are considered second-line smoking cessations. Zyban is first line. Let's move to the next question. Which of the following neurotransmitters does cocaine block the reuptake of? Is it acetylcholine, dopamine, norepinephrine, or serotonin? I'll give you 10 seconds to choose the correct answer. Blocks the reuptake of both dopamine, norepi, and serotonin. Now, cocaine increases norepinephrine, serotonin, and dopamine levels in the nerve synapse by inhibiting their neuronal reuptake. Now, the increase in dopamine are thought to increase addiction and dependence to cocaine via activation of the reward pathway. Now, the increase in serotonin provide feelings of confidence, while increase in norepinephrine increases energy in the cocaine users. CNS stimulants such as amphetamine, dexamphetamine, and methylphenidate also increase the synaptic concentrations of these neurotransmitters, and methylphenidate happens to work via similar mechanism of action to cocaine. That's just a by the way. So let's move to the next question, which reads: you learn that a patient is being rushed to the A&E at your hospital after crashing and snorting Adderall. Now, which of the following wouldn't be an unexpected serious adverse drug effect that the patient may experience? Is it arrhythmia, hyperpyrexia, hypothermia, or seizures? Which one wouldn't you expect him to present with? I'll give you 10 seconds to make a choice. So in my opinion, the correct answer is hypothermia. Now, when Adderall is taken at a higher than prescribed dose, or crushed, or snorted, or even administered via IV injection, then they can cause dangerously high body temperatures. It can lead to hyperthermia and not hypothermia. It can also lower the seizure threshold, leading to seizures, and an increase in adrenergic response, causing cardiovascular events. So apart from the other three, hypothermia would not be expected to happen. I would not expect it to present in this patient that we are expecting to be brought into the A&E. Let's move to the next question. Before we embark on this question, I just forgot to re-emphasize that to help lower misuse and abuse risks, patients should be informed that using prescription stimulants for proper indication and taking them as prescribed will decrease serious adverse effects. Now, crushing, chewing, or IV administration, or even snorting these stimulants like Adderall may alter the rate at which they are released. It may also affect their absorption and their bioavailability. And it is dangerous to consume alcohol with these extended release stimulants like Adderall, since there is a rapid release, or what we call dose dumping of such drugs. So they may not work the way they are intended to work. So avoid snorting, avoid crushing, avoid chewing, and avoid co-administering them with alcohol. Now our next question reads, which of the following best describes the proposed mechanism of action for Acamprosate, what we call Campral? Does it block an enzyme that metabolizes alcohol? Does it block the voltage dependent sodium channels? Does it interact with glutamate and GABA? Or does it interact with the endogenous opioid systems? I'll give you 10 seconds to choose the correct answer. Settle for C. It actually interacts with glutamate and GABA. It is structurally similar to GABA, what we call gamma aminobutyric acid. Thereby, it possibly increases the activity of the GABAergic system that leads to a restoration in the balance between neuronal excitation and inhibition by interacting with glutamate and with GABA. Disulfiram inhibits alcohol dehydrogenase, which is required for the oxidation of alcohol, thereby leading to an elevation in the levels of acetaldehyde, and that results in emesis, flushing, sweating, headache, and other unpleasant adverse effects of alcohol. So that A would only apply to disulfiram, not to this particular product. And then topiramate is the one that blocks voltage dependent sodium channels, not this particular drug we are talking about here. And then Naltrexone is the one that interacts with the endogenous opioid system, not the drug in this question, which is Acamprosate. All those three mechanisms of actions refer to other drugs, not to Acamprosate. So that's just by the way. Highly treasured viewers and listeners, that brings us to the end of part 19 of our Pharmacotherapy MCQs series. It was a pleasure imparting knowledge. I highly appreciate the fact that you sacrificed and made time to make part of my audience. Now, if this video helped you in any way, I would like to urge you to remember to give it a thumbs up and to like it. And if you haven't done so, I would like to request you to subscribe to my YouTube channel. I would like to make a promise that the best is yet to come. I'm very thankful you continue to partner with me in this venture, and I hope to interact with you in part 20 of our series. Thank you very much for being there for me. I appreciate your support.